It's a pleasure to communicate with him.
Thank you very much. It's a true honor to be here, even if I am here melting. When I left my home in Madison, Wisconsin, it was minus 20 and snowing, so I'm just a touch warm here in Kerala. So if you have any questions after the session, you can find me right in front of the air conditioning unit over there. My goal in the next 10 minutes is to try to make eyelid ptosis repair as simple as possible for you. In doing so, I'd like to highlight the two principal methods for addressing our most common eyelid ptosis problems, external approaches and internal approaches. In this lecture, I'm not going to address the sling procedures because Dr. Ashok is going to address them in great detail, and because they tend to focus on a very specific ptosis-related problem. The external approaches can also be termed transcutaneous and the internal transconjunctival. Sometimes the internal approaches are given different names, conjugulectomy, Fasanella Servat. I really think that both approaches are analogs to the exact same procedure, simply with an incision in a different place, and I'd like to explain that to you. First, I'd like to give you an oversimplified view of the relevant eyelid anatomy. And so, really the key anatomic points are your skin and eyelid crease. We typically do external ptosis surgery through an eyelid crease-based incision. The height of the eyelid crease can certainly vary among different backgrounds and different ethnic groups. In any situation, the eyelid crease incision is going to lead you through the orbicularis oculi to the orbital septum, which will then lead you to some point along the central fat pad, levator muscle, levator aponeurosis continuum. And we'll show you intraoperative pictures of the anatomy which highlight these points much better than an anatomical sketch. The levator muscle attaches in two ways. Fibers attach to the tarsus, as we know, and fibers also attach to the underside of the orbicularis oculi and skin, helping to form the lid crease. The other relevant muscle is Mueller's muscle, and this is just inside the conjunctiva from a transconjunctival approach, and so typically our transconjunctival approaches involve resection of the Mueller's muscle. However, if a muscle that elevates the eyelid is removed, that doesn't necessarily elevate the eyelid even more. I mean, if you have a muscle that flexes the arm and you remove it, the arm doesn't flex any better. So terming the operation a conjunctival Muellerectomy is nice, but it doesn't really talk about how this works, and I'm convinced that it works by plicating the levator the same way the anterior approach works. So as we delve into each of the two techniques, external versus internal, you might wonder, well, how do I choose? The external levator repair will correct a full range of ptosis as long as you have good enough levator function. If the levator function gets less than 10 millimeters, I start to get a little worried. If it's 6 millimeters or lower, then I wouldn't consider this procedure. If you're doing a blepharoplasty, you can use the existing incision. It's adjustable intraoperatively, which can be very nice in challenging ptosis cases or reoperations where a previous procedure didn't work. It can also be used if the patient wants to aesthetically modify their eyelid crease or contour. In addition, like the internal approach, it has short postoperative recovery with minimal morbidity. There is, however, a learning curve to this procedure. In addition, if you're going to do this procedure, you have to be willing to take your patient back to the procedure room to adjust them, and your patient needs to willingly understand that that's a possibility. There are some outcome studies out of the United States that show an up to 25% rate of reoperation in the first 6 weeks after an external levator repair. That doesn't mean those surgeons are all bad surgeons. It means that's just the nature of this procedure. So even though my own numbers are, well, less than that, there's still a fair number of patients that get revised. And so I quote the patients that 25% number so that they know there's a 1 in 4 chance we may go back to the procedure room to tweak one side. And that way when it happens, they think it's just part of the normal course, which in fact it is. So a brief overview of the technique. This can be done with either light sedation or local anesthesia with infiltration in the eyelid as well as a supraorbital block. When you infiltrate the eyelid, you have to be careful to keep the lidocaine very superficial and stay just in the subcutaneous preorbicularis plane with the infiltration needle. Otherwise, if you anesthetize the levator muscle, you'll definitely be taking your patient back to the procedure room for a revision afterwards. And then we begin with a lid crease incision, or this example actually involves a blepharoplasty as well, and I specifically photographed this procedure because the incision's wider and it shows the anatomy a lot better. So once we're through the skin and the orbicularis oculi and incise the septum, that's where training surgeons seem to start to get a little lost. And the thing to understand is that the septum is multilamellar. It's not like in the anatomical sketches where it's one layer, you just pop through and there you are. And so you have to be willing to dissect through the septum, slide the septum up and down, and you can see the fat moving underneath. And my landmark is usually the central fat pad. I like to come right down on that. It's harmless if you happen to overshoot your dissection a little bit. And then from there, it's easy to lift that up and find the levator muscle, the aponeurosis, and Whitnall's ligament. An alternative approach for this step of the procedure that works equally well is, at this point, to continue the dissection in a more inferior direction straight onto the tarsus. Let me go back. And then work your way from there backwards up into the levator muscle and aponeurosis. So the yellow underneath the septum here is the central fat pad. This forceps is grasping the levator aponeurosis and directing it inferiorly through the intact septum. When the septum's incised and the central fat pad is reflected away here, we have Whitnall's ligament, levator muscle, and levator aponeurosis nicely exposed. Having your surgical assistant put some tension on where you expect the aponeurosis to be helps speed this part of the dissection along. Then we put suspensory sutures into the tarsus in partial thickness fashion and through the levator in full thickness fashion. I tend to prefer 2 to 3. Some people do 1. I generally don't like to bet an operation on 1 suture. And then I always flip the eyelid to look from the back, no matter how superficial I think my partial thickness pass was through the tarsus, because some people's tarsi can be incredibly thin. These are secured temporarily, and I tend to like to pass the suture up by Whitnall's ligament and then just loosen it to a hangback as necessary. It saves the time-consuming tying and untying of the sutures that can happen without any decrease in the precision of the operation. We then sit the patient upright and adjust the sutures, and then the closure can really be any standard eyelid closure. They all work. Just to show that our operations really do make a difference in people's lives, and sometimes more than just the patient's life, this gentleman is an airline pilot who was about to fail his flight medical unless he got a ptosis operation. So if any of our American visitors flew American Airlines to get here, you can thank me after this lecture. Although I mentioned I generally don't do a one-stitch technique, there is an excellent paper by my associates in Madison, Drs. Lucarelli and Lemke, on small incision external levator repair, where you do the exact same technique but through an 8mm incision in the central eyelid crease. In my hands, I find a full eyelid incision still heals like a small incision anyway, so I'd rather just have the exposure. But this technique can be particularly nice in people who have decreased orbicularis muscle function, and as a fellow, Dr. Goldberg is actually the person who taught me to be very vigilant for that. It can also be a great technique in people who have horizontally short palpebral fissures. The internal ptosis repair corrects up to 2, maybe 3 millimeters of ptosis. The learning curve is easier because you're not dissecting through as many eyelid structures. It's also nice if you're operating on a patient with an ethnic background that you don't operate on very often, because it won't change the eyelid contour to be the eyelid contour of the people you do operate on very often. The disadvantage is really the limitation and the fact that it doesn't have the intraoperative adjustability. You take your best shot off the measurements and do it. We start with 6/0 silk traction sutures in the lid margin, And then we place 3 6/0 traction sutures through the conjunctiva and Mueller's muscle. And there is a nomogram for how much Mueller's muscle to resect, and therefore how high above the tarsal plate to place these incisions. I usually make my marks with an incisional handpiece before placing the sutures. As far as the resection amounts, there's a paper in American Journal of Cosmetic Surgery. This is openly available online at ajcsonline.org. In that paper, I actually have resection amounts of 5, 7, and 9 millimeters. I've since revised that to 6, 8, and 10, depending on the ptosis amount to correct. And if you want these and aren't able to jot them down, I can happily give them to you. Once those sutures are placed at the correct location, we lift them up. This lifts conjunctiva and also Mueller's muscle underneath, and you can imagine what the levator muscle is doing right underneath Mueller's muscle. We grasp that with a Putterman clamp, flush with the tarsus, and place 5/0 polypropylene sutures. I use a spatulated needle, just like I do for my tarsal passes on the external. The pass is just really, really easy if you do that. And we go in horizontal mattress fashion, back and forth, under the Putterman clamp. We excise the tissue against the clamp, and this leaves that Prolene horizontal mattress nicely in place. And then we return the eyelid to its original position and tie this loosely over the eyelid skin. So hopefully I've made the common ptosis repair operation straightforward for you. And if you have any questions, I'll be right near the air conditioner.